Okay, I think now my video is on, right?
Yes,
Yeah.
but I think you joined from
Mobile.
It's
from
echoing.
mobile, or you are connected with your
Oh, I
laptop.
am not feeling well. I've got viral.
No, that's
fever.
okay. Just make sure your two devices are not on because फिर ना वो noise पीछे करेगा.
Okay.
ठीक है, एक डिवाइस ऑफ कर देना. जिग्नेश अभी होल्ड करो जिग्नेश. Landing page. Yeah. Can we start, Jignesh? Okay. So, very good evening to all. I, on behalf of Diabetes India Oral Health Group, welcome all the delegates. The speakers for today's webinar were the masters in their specialities, Dr. Sujay Ghosh, Dr. Neeraj Gugnani, Dr. Rutul Gokalani, Dr. Jaideep Mahindra, Dr. Dominica. Our esteemed chairpersons, Dr. Amit Gupta, Dr. Ketan Mehta, Dr. Chandani, Dr. Abhishek Rai, and Dr. Priya Yadav. A big thank you to all of you for accepting our invite and being a part of this show. In the same breath, I would like to mention two names who are unable to join us as they are on their transit travels. That's Dr. Sujay Ghosh and Dr. Anuj Maheshwari. And I would like to extend a warm welcome to the Diabetes India Head Office representation, Dr. Bansi Sabu sir. Sir is the Secretary of Diabetes India and Chair IDF Southeast Asia, and Dr. Amit Gupta, who's a Joint Secretary Diabetes India. Thank you, sirs, for gracing this occasion. We also welcome Dr. Anuj Maheshwari in his absentia. Sir is RSDI President who has sent his video message, which will be playing in a while for now. The theme of this webinar is a challenging one. That's diabetes type 1 and oral health. Why I use the word challenging is because most of us aren't aware of the complexities of T1DM. I myself wasn't much updated on T1DM, to be frank on this, but with the interactive platforms of Diabetes India, I understand that one thing and the story behind T1D has a lot to say in terms of its own solo condition, the general impact it has, including on the oral health, it has on the individual and the day-to-day challenges he or she faces when you have to live with type 1 diabetes. And we are also honored that in this webinar today, we have a T1D champion who will be sharing her experiences with us in a while. She is yet to join. Cheers, Dr. Dominica. More power to you, girl. Also, I would like to extend an acknowledgement to our scientific partner, Haleon, the global brand name that all our dental fraternity knows. And it's truly a gum care expert in the sense. So with these few words, allow me to initiate the evening by introducing briefly our moderators for the webinar. Jignesh, intro slide. Intro slide. Okay, so a brief summary of the hosts that we are, four of us for the evening today. Myself, Sangeeta Di, I happen to be the chairperson for DIOH, ably chaired and co-chaired by Dr. Sumedha Bansal. She's a senior consultant in Faridabad and is a team lead scientific division. Dr. Anurag Satpathy is a professor and head at IDS Dental College Department of Periodontics, Bhubaneswar, and he's the team lead for the academic and research division and executive committee member of DIOH. Dr. Gunjan Gupta, she's a professor and head of Department of Periodontics, ITS Dental College, Greater Noida, and she is the lead of the Education and Awareness Division of DIOH. I take this moment now to bow down to seek blessings from the Almighty. Vandana, please.
सर्वदा वक्रतुण्ड महाकाय सर्वेषु सर्वदा
Thank you for the Vandana. I take a moment now to an opportunity to welcome the chief guest for the evening, Dr. Bansi Sabu sir. Sir is a known name of Diabetes India in the international front. He's the chief diabetologist and chairman, Care, Diabetes Care and Hormone Clinic, Ahmedabad. He's a global council member of EASD. He's a chair of International Diabetes Federation for Southeast Asia. He's a secretary of Diabetes India and Indian Academy of Diabetes. He's a vice president, Diabetes Asia Study Group. He's a founder of DTech, Diabetes Care India and India Swift Registry. Member Advisory Board, American Diabetes Association, and past president of RSSDI and AIRO. Sir is a recipient of fellowships from various organizations, to begin with American College of Endocrinology, College of Physicians, International College of Nutrition, and Royal College of Physicians. Sir has held and is in charge of various editorial positions. He's a managing editor for Sadiko's International Textbook of Diabetes. He has been an editor-in-chief of Journal of Nutrition, Metabolic and Health Science. He's the editor-in-chief of Diabetes and Metabolic Syndrome. Sir is the editor-in-chief for the RSDI Textbook of Diabetes. He is a recipient of various awards and achievements, to name a few: World Health and Wellness Congress and Awards, and has been awarded the Most Impactful Healthcare Leader, awarded by AACE, American College of Endocrinology, as the Global Clinician of the Year, and is the initiator of RSSDI Defeat Diabetes campaign for the World Diabetes Day. With these few words, sir, I welcome you for this webinar. Over to you, sir.
Thank you. First of all, Sangeeta ji, thank you for inviting me. Wonderful program which you are doing. It is Diabetes India and Oral Health Group, which is one of the most active and most productive health group of our Association of Diabetes India. Is one of the most productive interest group which you have created. Under your leadership as a head for this group, we have many people, particularly physicians, who have shown their interest in oral health because they understood the importance of the persons with diabetes, what's the importance of oral health, and that's what you have really created. Since last 3 years, we are doing, along with Diabetes India, a dedicated meeting. We also do a lot of webinars, activity, and you have done one dedicated meeting also in Delhi where I was there. We are going to do one more meeting this year in December at Udaipur, and I'm sure such type of even regional activities, regional meetings will also increase a lot of awareness. And today topic is again, you have taken very important topic, which is for type 1 diabetes. Now, two things I want to tell, that many people think that type 1 diabetes is a pediatric diabetes or it's a only pediatric disorder, but that's not true. We have a lot of adult also type 1. So here we may discuss more related to type 1 diabetes and their oral cavity problem related to young children or young adolescents, but definitely those young people who develop type 1 diabetes in their younger age, they continue to have this type 1 diabetes throughout their life. So you will have a lot of adults who also have type 1 diabetes since years. Now, why I'm saying you it since years, suppose someone is having a diabetes since last 20 years or 15 years, you can understand his dental condition or his gum condition, which will be much worse in compared to a person who had developed type 2 diabetes in the age group of around 50 or 45 or 60. So that's a very important issue. Then type 1 diabetes we also develop in adult age. So first time they are detected, but their sugar level are very high. And if they are not keeping very good control, that leads to also a lot of dental complication in person with diabetes. So these are some of the very important issues. And today we are very, very specific with type 1 diabetes and their oral health issues. So once again, I congratulate Sangeeta ji for this wonderful organization or the wonderful webinar which you have organized, inviting the experts. We have our expert or a close friend, Dominica, who will be also there, who herself is type 1 and she is a dentist. So, we have two things in her, and she can share her own experience as a dental surgeon or as well as a person with type 1 diabetes. We also have many experts who have joined from across the country. I'm sure they will share not only their experience or their uh, treatment point of view, but for them also, for dentists also, it is very important to understand difference between type 1 diabetes, type 2 diabetes, understanding how many of them are controlled, not controlled, on insulin therapy, not on insulin therapy. Because most of the dental surgeons, they just understand that you have a diabetes. But this is not just diabetes. They are type 1 diabetes. They are on multiple daily dose of insulin therapy. They are how much they are monitoring themselves. Are they keeping their sugar control? Because they are more difficult to have a good control of diabetes. So I mean, for dentists also, they should know more about type 1 diabetes. Today I am here at Jodhpur for a T1D breakthrough meeting, and beyond a Mewad Foundation who organized this meeting, which is dedicated for type 1 diabetes. So I'm here, and simultaneously we are joining for this webinar, which is dedicated again for type 1 diabetes. Once again, Sangeeta ji, thank you for inviting me. We can see my friend Amit also from Diabetes India. And if anybody, yes, Anurag, many more friends I can see here from Diabetes India, also Ketan and other doctors have joined. But my request to all team members of this interest group, if they can communicate, share the webinar link to many of our colleagues, doctors, it will be good for them to understand, listen more to the dental surgeon. At the same time, it is also equally important that you also share to your dental groups too, because they should also know more about the diabetes simultaneously. So that's the idea of creating this interest group is Diabetes India Oral Health Group is, to communicate between oral surgeon or dental surgeon or periodontist with diabetologist. Thank you. Once again, thank you, Sangeeta.
Right, sir. Thank you so much for your kind words. We have Dr. Amit Gupta, Diabetes India Joint Secretary, sir. A few words from you before we initiate the evening, Dr. Amit.
Thank you, Dr. Sangeeta. And Dr. Bansi Sabu has already given a lot of words of wisdom for this group. And it is always a pleasure to meet in this group, because I think this is one of the group which is very active from Diabetes India. Also, this is something which is not a regular stream in diabetes field, and that is why we face many challenges. But of late, if we look at the global scenario, recently ESD started last year. ESD had a symposium at the ESD, and this was a symposium between the ESD and the periodontology stream, and again signifying the importance of diabetes and the oral health. Similarly, there are a lot of couple of reports from the WHO as well, and American Heart Association, which talks about the link between the oral health as well as multiple cardiovascular outcomes, as well as the diabetes and pre-diabetes. So I think this is an exciting area, and people, all the experts, they need to understand that if they get engaged with this group early, probably we can establish a very sound, robust group, not only nationally, but as well as globally in the field of diabetes as well as the oral health. And many, many congratulations to Dr. Bansi, Dr. Sangeeta, Dr. Anurag, Dr. Sumedha, and all the leaders of this interest group, and those who have joined today and those who will be joining for the discussion. So over to you, Dr. Sangeeta, and to continue the proceedings.
Thank you, Dr.
This is
Amit.
for proud moment for Diabetes India, because we started this group before 3 years. ESD had done only last year.
Right.
So
Right.
we
And
are the leader in the world for creating
slowly,
dedicated
gradually, with
interest
your
group.
stepping stones, we are moving forward under your guidance, sir, I would say.
And you are very active also.
Thank you, sir. You guys are active. That's how gives us the momentum of keeping pace with your activities, sir.
Thank you.
Okay, Dr. Anuj Maheshwari has unable to join today. Sir is the RSSDI current president, but he has been graceful enough in sharing his video message for this webinar. Jignesh, please Dr. Anuj Maheshwari ka video message share kare.
Hi, myself Dr. Anuj Maheshwari, President RSSDI. RSSDI is a dedicated organization for research in diabetes and its complications. I am very much pleased to be a part of the inauguration ceremony of a webinar on type 1 diabetes and oral health, which is organized by the Diabetes India Oral Health Group. And I remember on this occasion that 13 years before I published my first paper in type 1 diabetes, with periodontal disease, and that paper has been published in the Journal of Diabetes India. At that time, Dr. Shaukat Sarikot was the editor-in-chief of that journal, and he was also the president of Diabetes India. And we were very much happy to get this publication. And especially I would like to share a few findings of this publication. In this publication, we evaluated the frequency of periodontal disease in a group of the patient with type 1 diabetes and its relationship with their diabetes, metabolic control, duration of the diabetes, and status of the complication. At the same time, we also did the comparison made of periodontal parameters like plaque index, bleeding index, pocket depth, and attachment loss in a group of the type 1 diabetes patient. And it has been compared with those who were not having the type 1 diabetes. A statistical analysis was performed to evaluate the relationship between periodontal parameters and degree of metabolic control, duration of the disease, and appearance of complications. And diabetics, those who are having the especially type 1 diabetics, had greater bleeding index, probing pocket depth, and higher clinical attachment level, and which was significant statistically. Patient diagnosed for the diabetes for shorter duration of time, like 4 to 7 years, showed bleeding index disease severity much higher with type 1 diabetes, and it has shown increased periodontal disease susceptibility. So with these findings, I believe that many people have done so much of the work with oral health and type 1 diabetes in last 13 years. But still, these findings are really the important mark on the periodontal disease, and we have established now periodontal disease as a sixth complication of diabetes. In type 1 diabetes, we found the correlation is more stronger as compared to the type 2 diabetes. So thank you very much for inviting me here. I am very much pleased to share my information, my own research on this platform, and I wish to all the success of this particular webinar which is being done on the oral health and type 1 diabetes. Some other time, whenever I will get more time, I will share this research in detail with all of you. Thank you very much, and best wishes.
Thank you, Dr.
We should
Amit,
thank
sir.
Anuj. But Sangeeta, one more important thing.
Right,
He
sir.
was professor of medicine in
Right,
a medical college, which is a dental college.
right, right.
And now he is currently a professor of medicine, which has been now dedicated only medicine student.
Right,
But
right,
he used to teach dental students for years together.
right,
And it's that publication I remember, which
Uh-huh.
he has done during Dr. Shaukat Sarikot, who was founder of Diabetes India.
Right,
And
sir.
it was published in our Journal of Diabetes India. Thank you once again, Anuj. We are missing you. And now over to Sangeeta. Thank you.
So aptly, sir has cited his publication in theme and relevance to the webinar, and we would love to hear him again. So with this, we initiate the evening for today, and the first session will be chaired by Dr. Amit Gupta. However, I make a note that the speaker, Dr. Sujay Ghosh, he is in travel transit, but he has gracefully shared his video recording, and which will be airing right now. So I take this pleasure to introduce a very dynamic, get-going diabetologist of the country, Dr. Amit Gupta. He's a medical director, Center for Diabetes Care, Greater Noida, adjunct professor, Department of Medicine, KMC Manipal, Mahe. He's a chair, IDF School of Diabetes. He's the executive director, Global Metabolic Health Alliance, which is just roaring and soaring high gradually over the time. Chair of American Diabetes Association, the Public Health and Epidemiology Interest Group. He's a secretary, Global Advisory Group, ADA. He's an executive council member, National RSSDI. He's a joint secretary, Diabetes India, vice president, ACP India chapter, ISMN, Asia Pacific Alliance for Integrated Prevention and Control of Diabetes. Honorary secretary, Diabetes Technology. He's a council member of Art of Living, Delhi NCR chapter. He's the executive editor of Sarikot, your textbook of diabetes. He's associate editor, International Journal of Clinical and Metabolic Diabetes. He's editor-in-chief for Diabetes, Journal of Diabetes and Endocrine Clinics. Over to you, Dr. Amit, to initiate the session, please. Dr. Amit. Over to you, Dr. Amit.
I think Dr. Sangeeta, I've already spoken at the inaugural address. So I think, and thank you for the kind introduction. Please proceed with the program. So we don't want to waste any time.
Okay.
So over to you again. Yeah.
Jignesh, please share Dr. Sujay Ghosh's intro slide.
Dr. Sujoy, he has sent his recording, I guess.
Yeah.
Okay.
Dr. Jignesh, can we have his intro slide, please?
Let me do the honor if we have the slide of Dr. Sujoy. Okay.
Intro slide.
Hello friends, good day to you. I'm Dr. Sujoy Ghosh, and at the beginning I would like to thank Dr. Sangeeta for having given me this wonderful opportunity to interact with you. Unfortunately, I'm unable to join live, and I have only 10 minutes to finish talking about pathophysiology and management of type 1 diabetes. So without type 1 diabetes is an autoimmune disease. That means the body is unable to recognize its own beta cells of the pancreas and therefore launches an immune attack on the pancreatic beta cells and destroys the beta cells of the pancreas and produce insulin. So if you look at the normal functioning, the beta cells produce insulin, which causes entry of glucose into the cell. In type 1 diabetes, what happens essentially is that there is an immune attack as a result of a background genetic disorder, followed by some possibly environmental or other factor which triggers autoimmune destruction of the pancreas. So that's putting it very simply how actually type 1 diabetes happens, and is often associated with presence of antibodies when it is called type 1A diabetes. If the antibodies are not present, then it's called type 1B diabetes. It is a disorder in which in India the average life expectancy is drastically reduced in a child with diabetes. So how do you recognize? So we tend to talk about the classical 4 key symptoms, that is increased toilet, increased thirst, weight loss, and unexplained lethargy and tiredness. Of course, some people might have polyphagia, and there might be blurring of vision and various other kind of symptoms predominantly related to ketoacidosis. We know for diabetes, the ADA has a diagnostic criteria. Any one of the 4, that is random glucose more than 200 with symptoms, fasting more than 126, 2-hour post-meal glucose more than 200, or an A1C greater than 6.5 in the background of what. So that we are all aware. Unfortunately, most of our children will actually land up with ketoacidosis, in which case we'll have to admit them and start management of diabetic ketoacidosis. And we've got to communicate to the family that this is an autoimmune condition and that insulin is life-saving. That's the most important key message. And whenever in doubt about the type of diabetes, please treat with insulin. Academics can take a back seat. And there are certain lab investigations that we need to do in such individuals before we think of other things, and of course initiate insulin therapy. And we have to have a solid, we'll talk about it a little later. Amongst the lab investigations and clinical examinations, the anthropometric growth monitoring, particularly in children, is very important. Blood pressure, A1Cs every 3 months, thyroid function test, because these children are more likely to have autoimmune thyroid disease, blood glucose, blood counts, function tests, creatinine, and particularly if you're from northern and western India, celiac screen will also be needed. And on a regular interval, screening for comorbidities. Like I said, insulin is the backbone of therapy, and we'll talk a little bit about the insulin because that's the most important bit of management. Aware of the different kinds of insulin regimes that have come across. And to cut a long story short, we'll have to think of only 2 kinds of insulin, either regular insulin or rapid insulin, which we will be giving before long-acting insulin, which will cover for the basal insulin. So in most of the situations, it's going to be either large in 100, large in 300, or even receiver rapid-acting insulin that we were using. So this is the insulin action profile of the various insulins that we are talking about. The rapid or the short-acting insulin with a long-acting. Typically used in a basal bolus regime. Please remember, do not use premix insulin in type 1 diabetes. If you are using subcut insulin, the only regime that you should be following is a basal bolus insulin regime. And I'm not going into the details of how much of dosing of what in the basal component of insulin required, particularly in a younger child, will vary anywhere between 30% to 50% of the total daily dose, and the rest of the boluses will be divided into 3 to 4 meals as per as the requirement of the child. These are the insulin injection sites. Predominantly, we tend to give the rapid-acting insulin in the abdomen, and the long-acting insulin in the anterior and outer side of the thigh. Education has to be provided about insulin nutrition, otherwise you will end up with lipoatrophy and lipohypertrophy. Needles is also something which is very, very important. We educate the patient and the family about the insulin absorption and how things can go wrong. Various kinds of insulin delivery systems like the pens, the syringes, the needles. Always remember, if you're particularly using syringes, match the strength of the syringe with the strength of the vial of insulin that you are currently using. Apart from this, you can have other insulin delivery devices that we'll talk about, and to think of probably using the smallest needle, the thinnest needle, so that it causes less pain. This talk is restricted to subcut insulin. We can't talk about insulin pumps in such a short talk. We'll have to also educate the patient, the family about the insulin rotation, the storage, particularly have facilities for refrigerator at home, that it can still be stored in a earthen clay pot here. We talked about the simplification part. Kids will actually land up
अरे यार તમે કાલે મંગાવી હતી ને આપણે આજે આવી
કાલે કીધું સાંજે એટલે સાંજે ઓર્ડર
સાંજે કે અમે તમને સવારે જ કીધું હતું દાદા
actually
એટલે અમે
from the clinic, provide them with the supplies of the consumables that I talked. Then adequate follow-up, whether it's the non-communicable disease clinic of a district hospital or their private. Now, insulin is one bit. It's like the sword. Now, you need a shield to tackle the battle, and that shield is your glucometer within the. You'll have to educate the patient and the family as to how to go for SMBG charting and what targets are, and them how to document that. Remember, always cross-check the logbook reading with the glucometer reading, because there might be inaccuracies that might. And we also have to teach how you actually adjust the glucose and the insulin dosing. It has to be, otherwise you'll end up with problem. Finger pricking is painful, so we'll have to teach where to prick, how to rotate, what size needle to use, pain of the pricking devices. So the monitoring, we've got to teach them about HbA1c and what the individualized targets would be. Measuring urine ketones will be important, particularly when a child is sick. So we have to teach them the sick day rules. That is, on a day that the child is ill, teach the mnemonic SICK. S means check sugars more often. I means might need more of insulin. C means ensure that the child will also have to educate them about nutritional aspects. There's so many things I can't. One of the things that we need to talk about is, for example, the carbohydrate counting. This is something that we will have to talk to them about in terms of the cost. Second thing that we've got to talk to them about is the glycemic index of food as well as the glycemic load of food, so that there is a balance between the amount of carbohydrate that an individual is taking and that it should preferably be of a lower glycemic index, unless and until you're. This concept we need to teach about carbohydrate exchanges and about exercise and physical activity. That is going to be very important. Apart from this, providing psychological support to the family as well as the child. This can actually be found in a new national guideline that we've published on behalf of the Government of India. I'm proud to be part of it, the guidance document produced by the Government of India under Rashtriya Bal Swasthya Karyakram. Listening.
Okay, there is a temporary internet issue that we are facing from the event team. So kindly bear with us. They'll be just shutting it down and resharing. So kindly stay put, please, everyone. Jignesh, please, jaldi se fix kariye. Jignesh, yeah, please, fast. Thank you, Dr. Sujay, for your wonderful presentation. There was a bit of a disturbance in between. So we now move on to the next session, and over to Dr. Gunjan Gupta for introducing the chairperson for the next lecture, please. Dr. Gunjan?
A very good, a very good evening to one and all. I'm here to introduce Dr. Ketan K. Mehta. He is the president IMA Mumbai West, Honorary General Secretary, Vice President IMA Maharashtra State, Organizing Secretary ISECON, Honorary Joint Secretary ICP, Honorary Joint Secretary NSHP HERE, Trust Board Member of MMA.
Gunjan, it's all fine. Let's go. Let's hear from our speaker. Yeah. Thank you. With your permission, can I start?
Okay,
So,
as you say.
yes, thank you so much. Very good evening to one and all. And at the onset, would like to thank the special interest group of especially Dr. Sangeeta Madam for arranging this webinar. And let's hear a very interesting next subject, which is on type 1 diabetic, pediatric oral complications and management. And to discuss this topic, we have eminent faculty with us, Dr. Neeraj Nandani from Yamuna, who would be deliberating on this subject. Dr. Neeraj Gangnani is, of course, has been a part of Diabetes India Oral Health Group for quite some time. He has done his MDS from KGMC Lucknow. He is the Professor Department of Periodontics and Preventive Dentistry at Dow Dental College. He has been having a master's degree in higher education from University of London. He has got his special interest on the preventive dental care also. He has more than 90 publications to his credit and currently is serving as the associate editor of International Journal of Pediatric Dentistry. With this word, may I invite Dr. Neeraj Gangnani to start his presentations. Thank you. Sir, you will have to unmute, sir.
Is it visible?
Yes, sir.
Thank you. Thank you so much, Ketan sir. And at the very outset, I convey my sincere thanks and gratitude to Dr. Sangeeta and all the members of the Diabetes India Oral Health Group and the Diabetes Group present over here, all the dignitaries and all the participants. So today we are gathered here to speak on, to discuss on about a very important topic, type 1 diabetes. And I have been given the task to speak on oral implications and management. So as in the first lecture, we have heard that it's an autoimmune disease in which T lymphocytes selectively destroy the insulin producing beta cells, leading to no or so much decreased insulin. And there is increasing incidence both globally and in India. The point is that it impacts all the major organs of the body. We know that as per recent guidelines, diabetes is now not considered only diabetes, it's more of a cardio-renal disease. So we should understand that type 1 diabetes also impact all the major organs of the body. We are discussing today oral implications. In regarding to this, I must first of all tell that there are no specific oral manifestations of type 1 diabetes mellitus, but it makes the child or the adult prone to certain infections and other dental diseases. So I would not say there are complications directly, I would say there are implications. So there are many oral implications, and the more important one are xerostomia, impact on dental caries, the periodontitis and gingivitis, as we heard in the introductory speech by Dr. Anuj, impaired tooth eruption, delayed wound healing, candidiasis. The most important thing I want to convey over here is that it's not sufficient to know that these are the oral implications. We as dentists should be prepared to combat these. Some of these are completely preventable, provided the child, we are able to focus on the preventive strategies and the glycemic control for the child. So that's why it's important for us to understand the pathophysiology. Then only we'll be able to prevent or provide appropriate preventive strategies to the child. So coming to the first one, oral implication, xerostomia. Xerostomia in children with type 1 diabetes has a multifactorial etiology. In this, we can see that there is microangiopathy, osmotic diuresis, autonomic neuropathy, which means decreased secretion and decreased parasympathetic drive, and some glandular changes in the salivary glands. Collectively, they lead to reduced salivary secretion. Now, it is not only the amount of the saliva that gets decreased, but the quality of the saliva also gets altered. So there is reduced flow and thick viscous saliva. Collectively, this reduced flow and viscous saliva makes the oral cavity prone to all the dental disease. So if we see this forest plot during a meta-analysis, we can understand that the saliva, the overall mean saliva actually decreases. It is lot much less than a normal child. So patients without type 1 diabetes mellitus and the patient with type 1 diabetes mellitus, there is a lot decrease in the total amount of saliva. So what is the implication of that? The implication is that it's not only the complaint of dry mouth or the sticky saliva, but the patient may also complain of difficulty in swallowing when speaking. There might be altered taste, cracked lips, increased thirst. But these are just the clinical features of the xerostomia in type 1 diabetes mellitus. This xerostomia is actually leading to so many problems, which includes higher risk of caries, higher risk of periodontal inflammation, increased susceptibility to oral infections, and so on. So xerostomia is one of the major contributing factors. No doubt xerostomia is occurring because of type 1 diabetes mellitus, but it makes the child prone to so many dental and oral implications. So we should be definitely treating xerostomia because that is the major duty of us as the dentist. So whenever we encounter a patient with xerostomia or with known type 1 diabetes mellitus, we should really act upon very smart. So what can we do? We can optimize glycemic control. We should maintain adequate hydration. We should provide the chewing gums that can provide the stimulated salivary flow. Pharmacological saligogues only when indicated as per age. We should focus on prevention. What does it mean? We should definitely be focusing on use of twice daily brushing because xerostomia will ultimately lead to oral dysbiosis, leading to making the child more prone to oral disease. Then comes the symptomatic relief. For this, it is important that we understand that we have to avoid any alcohol containing mouthwashes because because of the desiccation property of the alcohol, they further cause dryness of the mouth, and that's what we do not want. So we provide oral moisturizing gels which are comfortable for the child with xerostomia. Coming to the second implication, dental caries. The common thought might be among the dentist and the diabetologist is that dental caries might increase in case of type 1 or type 2 diabetes mellitus. But the point is that the studies are contradictory. Several studies states that there is no difference between the DMFT index in the children with type 1 diabetes and in healthy controls. But one thing is very sure, no doubt there is not significant differences found in many studies, but one thing which is very sure that type 1 diabetes do increase the caries risk. Now, caries risk is dependent upon various protective and offensive factors, and the factors that are present in the patients with type 1 diabetes mellitus is decreased salivary flow, increased salivary glucose, decreased buffering capacity, and all these things lead to cariogenic biofilm shift. So the patients are definitely of higher caries risk, but if we act smart, if we focus on the protective and the preventive factors as a dentist, we can really make the child not suffer from dental caries so much. So whenever we see a child with type 1 diabetes mellitus, our mindset should not be that, okay, he is type 1 diabetes, so caries will definitely occur or gum disease will definitely occur. Rather, we should have a more protective, high risk preventive strategies that is to be applied for such patients. So you can see in this forest plot also that the mean difference is favoring the control group. So if you see any of the individual study, these are the experimental, that the children with the diabetes, and these are the control group without. So DMFT index in all the groups, in all these studies was higher in the experimental group. So no doubt the difference is not much. It's 0.41 and but the values 0.03, the lower end of the confidence interval is also very close to the null value, but still we should know that the caries risk is high, but the DMFT may not be so much different. Now what can we do? We should understand that there are risk factors and then there are protective factors. We should always focus on the protective factors, focus on good metabolic control, good fluoride exposure, definitely both systemic and topical, good occlusal sealants, effective oral hygiene, plaque control methods, regular dental visits. Like for high risk, we always say every 3 months dental visits, balanced diet. So rather than just focusing or just presuming that there are so many risk factors which might lead to more caries, our focus should be on the protective factors, and these are the protective factors we all know as dentists, but objectively applying to the patient of type 1 diabetes mellitus is the key to prevent them. Coming to the third very main implication, gingivitis and proneness to periodontitis. We know that metabolic disturbance in the type 1 diabetes mellitus actually leads to dysregulation of the host response, which includes microbial dysbiosis, the most important thing. And this microbial dysbiosis lead to biological consequences, that is increased inflammation, increased collagen breakdown, impaired healing, leading to multiple clinical manifestations in the form of gingivitis, increased bone loss, and proneness to periodontitis also. So the third forest plot that I'm showing you is the mean difference in the gingival index. And even in the first introductory speech, Dr. Anuj also mentioned his first study about the oral manifestation, and he told very beautifully how all the clinical features that represent gingivitis and periodontitis were higher. The scores were higher, depicting the severity of the disease in the children with type 1 diabetes mellitus, and this forest plot also depicts the same thing. The more important point here is that we can go to any number of systematic reviews. All these studies show similar findings with respect to cal, bone loss, periodontitis, and calculus. So it's important to understand that type 1 diabetes mellitus leads to some metabolic disturbances and oral dysbiosis, which makes the children prone to both the inflammatory gingivitis and periodontitis. So what can we do? We can definitely provide good oral health care, as I discussed in the previous slide. All the factors that can prevent the disease should be our key. Now the next is the impaired tooth eruption. So there are inconsistent findings. Children with diabetes exhibit accelerated tooth eruption, but the findings are inconsistent. The point is that different studies have been done in different ages, and they show that 11.5 years is considered as a threshold. Till that time, there is accelerated tooth eruption, and if the child is beyond 11.5 years, there is delay in dental development. Now, some of the dentists, you might think that about 11.5 years is the age when almost all the teeth have erupted, but we should understand that there is a difference between tooth eruption and extra-alveolar eruption. So active and passive eruption is going on. So initially, you might find that all the teeth are erupting very fast, but as the child matures, there is delay in dental development. Now, how does it implicate? So this is a subtle observation that such aberrations are linked with malocclusions, impaired oral hygiene, and periodontal disease. So we should be just guiding the patient. This is one of the findings which we should be keeping a record in our OPD cards and guiding the patient that there is no need to worry about the aberrant or the impaired tooth eruption, and we are keeping an eye on it. The next thing is the delayed wound healing. Now, whenever there is any oral trauma, oral surgery, tooth extraction, so healing occurs by sometimes primary intention or secondary intention, but both type of healing requires tissue regeneration and osseous healing. And unfortunately, both these things are delayed or poor in case of type 1 diabetes mellitus. The most important line here is that delayed wound healing is primarily associated with poor metabolic control. It's not a direct implication of type 1 diabetes mellitus. So that means if the child is having good glycemic control, or we should promote a good glycemic control, then the wound healing might not be so much delayed. So what is the role of pediatric dentist? Schedule elective procedure when the diabetes is well controlled. I think we all take care of this thing. Achieve as much as atraumatic surgical techniques, ensure effective hemostasis, provide meticulous post-operative instructions. Recall is a very crucial factor in such patients, and liaise with the diabetes care team if the healing is delayed or infection develops. Very, very important. So the next is the candidiasis. We know that candidiasis is a normal commensal, but as soon as the oral immunity falls, the candidiasis develops as a disease. So children with poorly controlled diabetes are at risk of candidiasis. So the pathogenesis is again multifactorial, and as in other disease. So chronic hyperglycemia, increased salivary glucose, xerostomia, impaired immune function, most important, and altered oral microbiosis. This is the main thing. So role of probiotics is also so much in such patients. So these all leads to the candidiasis. It's important to understand that there are different clinical features of candidiasis. It may appear as pseudomembranous candidiasis, erythematous candidiasis, angular cheilitis, or simply burning sensation. Here it is very important to understand that most of the children that will be coming to a dental office would already be diagnosed with type 1 diabetes. But if a child has still not been diagnosed because of multitude of reasons, but if he is coming back to you again and again with pseudomembranous candidiasis, that is oral thrush, that might be a point to check if there is any type 1 diabetes mellitus. So if you see a patient with recurrence of candidiasis, you should definitely check for the presence of diabetes. So how you can manage in dental clinic? The first thing is that confirm the diagnosis, identify the clinical form, treat the infection. How we can treat the infection as a dentist? We can treat the mild infection by topical antifungal therapies like nystatin, miconazole oral gels. But if it is severe or moderate, we can add oral fluconazole. The third thing is very important is addressing the underlying cause, because I told you it is the glycemic control that makes the child more prone to the aggressive candidiasis. So controlling of the HB1AC and managing the xerostomia. Again, antifungal therapy will only treat the infection. So the second step will only treat the local infection, but optimizing glycemic control is essential to prevent recurrence. That's why I told you that if a patient comes to you with recurrence of type 1, the oral candidiasis, that is the point where we can really intervene in the child's life. So last is the odontogenic infections. Poor metabolic control is again a major determinant of infection severity and risk of spread. Many a times we try to treat a patient who is already having a need of a root canal treatment or minor or major surgery. That time we should be very cautious, because if the diabetes is there, if the HB1AC is higher, then these children are more prone to spread or delayed healing of odontogenic infections. So this is again because of impaired host defense and impaired tissue repair. What as a pediatric dentist or a dentist we can do? We can eliminate the source of infection. That is more important, because we do not want the infection to spread or a localized infection to become a facial space infection. So drainage, extraction, endodontic treatment done in a conservative manner is always mandatory. Glycemic control, antibiotics when clinically needed, and refer urgently for any facial space infection, because in the presence of a high HB1AC, the spread of infection is too fast. Systemic toxicity can occur, dehydration, or if you see a suspected diabetic ketoacidosis, this is a patient for hospital-based dentistry. Do not try to manage such patients, child or adult, in sole dental clinics. So what are the essentials before dental treatment? So if a patient is coming to you, I'm not talking of all the oral implications. If a child is just coming for an elective care for a dental treatment, what can you do? You should focus on these points. Check HB1AC, confirm meal and insulin timing. As we saw by Dr. Ghosh lecture, it is more important to understand the meal and the insulin timings, because these children have to take multiple insulin shots also to maintain their glycemic control, which is actually difficult to be managed as compared to type 2 diabetes. Morning appointments. Recognize, as a dentist, we should understand, no doubt patients are already aware of the hypoglycemic attacks, but as a dentist, we should also be aware of the hypoglycemic attacks that might occur. So for that, keep glucose or sucrose available, avoid prolonged fastings, and know when to defer elective treatment. That is more important for us, because HB1AC and the fasting blood sugar level should all be maintained. Now, what is my take-home message? I have two messages for you. The first thing is that type 1 diabetes affects oral cavity in multiple ways, and we as a dentist should be aware of all the ways. Just being aware is not enough. We should know that these diseases, these oral implications are preventable up to some extent, and these children the approach should be very much focused. We should understand that the parents and the children are already burdened by the unsurmountable needs to manage the type 1 diabetes, but still we should make them understand that oral cavity is a gateway to their systemic health, and we should promote the prevention of the oral disease in such. What should you do as a dentist? Be aware that type 1 is a common and rising worldwide. Screen every patient for medical history at their first dental visit. Implement preventive strategies to reduce oral complications, and collaborate with the diabetes care team. And I know that this is the beautiful platform where I'm able to see senior diabetologists and dental surgeons, periodontists, who are coming together to prevent and manage these children in a beautiful way. So we should join hands together to help these children achieve the optimal health. My final message is that every child with type 1 diabetes deserves a healthier life. And as dentists, as pediatric dentists, as periodontists, we have the privilege and the responsibility to help make that possible. With these words, I once again thanks everyone. Thanks, Dr. Sangeeta. Thanks, Dr. Ketan, and everyone, all the audience for the patients listening. Thank you so much.
Thank you, Dr. Neeraj. It was such a fabulous presentation. I started wondering whether are you just taking care of the dental management, or you are also taking care and giving a lovely message for blood sugar control. So I would request all the delegates to put their questions in the chat box. And from here, we end this session. We'll take up the questions at the end. Thank you.
Thank you so much, sir. Thank you. Thank you. Thank you, ma'am.
Thank you, Dr. Neeraj. That was a fabulous, fabulous lecture, and it was very much expected of that level to come from you. And thank you so much for that. And over to the next talk. And here I would like to invite Dr. Anurag Satpathy to introduce the next chairperson. Over to Dr. Anurag.
Thank you, ma'am. Very warm welcome and good evening to all the dignitaries. We are happy and thankful to have Dr. Chandni R, who will be chairing this session. She was formerly Professor of Medicine and Head of the Department of Emergency Medicine and Principal, Government Medical College, Kozhikode, Wayanad, Kerala. She has been in medical education since 1998 and had been in the governing body and member of Associations of Physicians of India. She has been a past chairperson of RSSDI Kerala chapter and API Kerala chapter. She was awarded as the Best Doctor Award Modern Medicine Medical Education 2018 by Government of Kerala. She has also been won the Best Teacher Award in 2019 by the Kerala University of Health Sciences and has been a member of board studies of the same university. Also, wonderfully, she was awarded as the Woman Physician of the Year Award by ACP India Chapter in 2025. She's a state coordinator, diabetes protocol treatment algorithm of the state of Kerala 2017 and had been a principal investigator for several multicentric international clinical trials. Thankful to Dr. Chandni to be here. Over to you, ma'am. Thank you.
Thank you, Dr. Anurag, and I really congratulate Dr. Benshi Sabu, Dr. Amit, and Dr. Sangeeta for bringing this Diabetes India Oral Health Group and this wonderful webinar. Many congratulations, and I'm very happy to chair this session. And after the wonderful presentation by Dr. Neeraj, we are moving on to the next speaker. He's none other than Dr. Rutul Kokalani, and we have been hearing how important it is understanding and managing the oral problems in type 1 diabetes and the metabolic control and the preventive strategies from the previous speaker as well. And I'm very happy to introduce Dr. Rutul, and he's visiting consultant at HCF Ahmedabad, and he's fellow in diabetes and postgraduate in diabetes from Czech Republic, Greece. And he's certified in diabetology, national executive member RSSDA, and he's founder Diacon and he has many other
Ma'am, thank you very much for kind introduction. I guess
a long list, and I'm very happy to welcome and to the important topic, considerations for management of dental treatment in type 1 diabetes patient, a diabetologist viewpoint, and welcome, and over to Dr. Rutul Kokalani. Over to you, please.
Thank you, Dr. Chandni, ma'am, for kind introduction. And I'm really delighted to be here at our own Diabetes India special interest group meetings. Anytime when I'm invited, I'm really happy because this is what I've been one of the part when it was all starting, and now I can see that how much it has grown. So thank you very much, Sangeeta Dheer ma'am, Bansi Sabu sir, and everyone who is present here. So I'm sharing my slides without wasting much time. Hopefully my slides are visible.
Yes, yes.
Yes. So my topic is consideration for management of dental treatment in type 1 diabetes, and a diabetologist viewpoint. It is very important because what usually we are seeing is that we are getting referrals from our dentist friends, but we never think on our side that what problem they are facing and what guidelines they should follow. Though after this special interest group and Dr. Sangeeta Dheer ma'am has taken up this charge, it has changed the scenario in many ways. So, and my topic is specifically for type 1 diabetes, which is very much important in dental management and dental procedures, especially. So, the sugar smile axis, why it matters, is the theme of this today's webinar. So, diabetes and periodontitis are not two separate clinics. They are one inflammatory continuum the diabetologist can influence. And I feel that all our diabetes patients, whether it is type 1, type 2, or MODI, LADA, all the patients should be we should ask them to check regularly their dental for their dental health, because there are the slides which I am going to show is really eye opening, where 783 million adults projected to live with diabetes by 2045. So this is why we need to understand it more, that our diabetic population has higher chances of periodontal diseases. 50% of adults with diabetes affected by periodontitis, the sixth complication. It is one of the most important complication, and anyone's health starts with their mouth. So 26% increase in relative risk of incidence in diabetes in people with periodontitis. So the people who are living with diabetes has higher chance of periodontitis. 24% higher incidence of periodontal disease in people with diabetes. So the people who are living with diabetes has higher chances of periodontal disease, and who has periodontal disease have very high chance of having diabetes. So as a diabetologist, oral health is modifiable determinant of glycemic control. Screening, referral, and co-management of mouth are legitimate part of comprehensive diabetes care, and it's not an afterthought. So usually both way, if we see, diabetes is also modifiable risk factor. If we keep it in control, blood sugar is in control, then definitely it is going to reduce the complication, including periodontal disease. And if we have periodontal disease, and if we can reduce this inflammation and infection, then it is also going to change the blood sugar level. So this is a bidirectional pathophysiology, as I was telling from very first slide. If you have chronic hyperglycemia, you have advanced glycation end products, excess, rage, and age end products. And this excess increase the oxidative stress. It also increases inflammatory markers like uh, interleukins and TNF alpha, and neutrophil dysfunction is there. So ultimately, it causes periodontal tissue and bone destruction, which leads to bacteremia and increase in CRP level, and so ultimately inflammation is increased. It also causes systematic insulin resistance due to higher inflammation. So it destabilizes blood sugar, and ultimately it increases HbA1c, and glucose variability is high in those patients. So again, this chronic hyperglycemia and this cycle goes on and on. It's a vicious loop, not just a cycle. So mechanistic bridge where insulin resistance is induced by periodontal derived cytokines, even in type 1 diabetes, where it worsens the insulin dose response and destabilize control. The bigger problem in type 1 diabetes is average HbA1c in India for type 1 diabetes is more than 8.5 or 9%. So there, this chronic hyperglycemia has higher glycemic variability. In type 1 diabetes, we know that it is treated by insulin alone. So glycemic variability is high in any case. And if you have periodontal disease, if you have any infection, then ultimately this infection and inflammation is going to increase this variability, and it is going to increase the complication by multiple fold. So oral manifestation to anticipate in type 1 diabetes is very important. Recognizing this lets the diabetologist read the mouth as a window on glycemic control. It's a very important statement. Periodontitis and gingivitis are earlier onset and greater attachment loss and worsens with disease duration. So whether it is periodontitis or gingivitis, they are going to increase by time, duration of diabetes, and glycemic variability along with higher HbA1c. Xerostomia, where hyposalivation is there, where autonomic neuropathy and hyperglycemia, they reduce salivary flow, which is also one of the problem of type 1 diabetes. Oral candidiasis, any fungal infection which is related to hyperglycemia is very much problematic. So denture stomatitis, angular cheilitis, median rhomboid glossitis, this all are the complication of this oral candidiasis. In type 1 diabetes, it is more. Delayed wound healing is also there if you have gone for surgery or procedure. Impaired neutrophil function and microangiopathy, they increase the risk of infection. Burning mouth or dysgeusia, it is also one of the bigger problem where small fiber neuropathy and taste disturbance predicts the neuropathy onset. Ultimately, this burning mouth is due to uncontrolled blood sugar, which leads to which is the result of small fiber neuropathy. And our many of our patients come up with such complaint, then what we do, we ask them to go to either dentist or ENT surgeon. We can't answer them, because though it is a neuropathy and it is the complication of uncontrolled blood sugar, and still sometimes we miss that. Dental caries where salivary glucose, low pH, and poor hygiene raise the cervical or root caries. These dental caries are also common in type 1 diabetes with uncontrolled blood sugar. So quantifying the risk in type 1 diabetes, the association is not soft. Hard cohort data show a graded and duration dependent hazard, where you can see the risk of periodontitis is almost 45% higher in comparison to non-diabetic population in type 1 diabetes. So in type 1 diabetic population, it is almost 45% higher. So almost periodontitis hazard with frequent diabetes, ER visits and admissions is almost 13 times higher. So almost 0.27% to 0.8% HbA1c fall achievable at 3 months after periodontal therapy. So if you treat periodontal disease properly, then it is going to reduce HbA1c by 0.5% almost, which is almost like a DPP-4. Severity climbs with diabetes duration and poor control. We know that if less than 5 years of control, then it is going to have longer duration and variability. Poor control ultimately leads to attachment loss and mobility and tooth loss as well. So greater cumulative glycemic exposure lead to more severe periodontal breakdown. pre-treatment risk stratification by glycemic control. So you need to know if HbA1c is less than 7%, then definitely you can go for procedure. There is not a problem. It's a good control. If moderate HbA1c is there between 7 to 8%, then even you need to be cautious. Peri-operative glucose checks are required, and coordinate with physician and ask them to reduce HbA1c as much as possible and try to achieve less than 7%. Sometimes we compromise with 7 to 8% because we don't want to lose our patient. Sometimes it happens in our patient as well when they are asked, our dental friends ask that, sir, his HbA1c is between 7 to 8. Should we go for procedure? And we say that it's okay. Let's see. We'll control it after. But let's not forget that it increases uh, periodontal diseases and other problems and infections by multiple folds. So if HbA1c is more than 8%, then you can go for elective surgery, treat urgent needs only, optimize glycemia first, and antibiotic cover if infection is there and HbA1c is more than 8%. So the pre-dental diabetology handoff says that what the diabetologist should communicate to dental team before invasive procedure. Latest HbA1c should be there, and set risk tier, decides elective versus deferred surgery, ask them to delay the surgery if HbA1c is more than 8.5 or 9% for at least 15-20 days, unless we control their fasting and postprandial 3 to 4 readings. Hypoglycemia history is there, then be very much aware. This is also very much common when we try to achieve tight glycemic control, especially in HbA1 in type 1 diabetic patient. Then the chances of hypoglycemia increases, and this HAAF, hypoglycemia associated neuropathy, and it is a bigger problem, and this is impaired awareness of hypoglycemia is more dangerous than even having symptoms of hypoglycemia. So we need to have rescue plan, insulin regimen and timing, whether the patient is on multiple daily injection or patient is on pump. In our patient, must be, most of our patients are on MDI therapies. Our 99% of patients are on MDI therapy, so treat them accordingly. CGM and SMBG data and TIR, we all understand. I'm going to explain it in next few slides. Micro and macrovascular complications where neuropathy, cardiovascular disease, neuropathy affect drugs and positioning. Renal function and drugs where guides antibiotic and analgesic doses. We should avoid NSAIDs, especially in this patients who has renal dysfunction. Agreed glycemic target, where we should try to achieve the best possible glycemic target. So in which procedure preferred HbA1c is what? This is what it is beautifully given. So if you are just cleaning and restorative procedures with examination, then HbA1c less than 8 is okay. If scaling root planning, then 7 to 8% of HbA1c is quite okay. Simple extraction, then less than 8% HbA1c, but I would say less than 7.5 would be better one. Surgical extraction and perio surgery, then we should try to achieve less than 7% or maybe 7.5. Dental implants, bone grafting, which are longer surgeries, and where we try to achieve less than 7%. And in any procedure, if HbA1c is more than 9.9%, then optimize it first. Plan for surgery properly and give the time. Hypoglycemia, where number one chair side emergency in type 1 diabetes, because at our clinics we can definitely manage this complication, and with daycare management or even IV infusion of glucose or dextrose. But the problem is in dental clinic, when they definitely get panic if the blood sugar is less than 70. We all know, understand the symptoms of hypoglycemia, that I don't need to explain. But if your patient is sweating, tremor, pallor, tachycardia, anxiety, confusion, irritability, severe hunger, tingling around the mouth, then that could be, and slurring of speech and drowsiness is also very important. So uh, why it is mixed? Because this patient may have paresthesia due to local anesthesia, and maybe due to hypoglycemia as well. So impaired awareness is the bigger problem and may progress silently, and suddenly patient may fall into severe hypoglycemia, and sometimes we get so panicked that what to do, and then you are in between procedure. So this is why we all need to understand that impaired awareness of hypoglycemia is bigger problem, especially in type 1 diabetic patients. So 15-15 rule, you all must be aware of this 15-15 rule. So stop the procedure in hypoglycemia, keep airway clear, remove everything related to your procedure from the mouth. If the patient is conscious, give 15 gram of fast oral carbohydrate. Wait for 15 minutes, recheck blood sugar. If less than 70, then repeat it again with 15 gram of glucose. If patient is unconscious, then do not give oral. IM or subcutaneous glucagon can be given, or IV dextrose can be given. Do not give oral in case of unconsciousness. Recover and give complex carb snacks and active EMS if no response. So emergency services can be provided if there is no response. Appointment planning, timing, diet, and stress. Schedule early morning to mid morning, where endogenous cortisol makes glucose more stable. Never, never treat Never treat the patient in fasting. Confirm the patient has eaten a normal meal or taken usual insulin, especially in type 1 patients. Keep visits short and low stress. Endogenous adrenaline and cortisol drives stress, hyperglycemia, and stage long work. Check glucose before and after baseline plus post-operative reading for invasive or prolonged procedure is important. So this is not common in a dental clinic, but when the patient is type 1 with type 1 diabetes, then you need to follow this all procedures. This is very much important. So this seems like, yes, हम तो मॉर्निंग में ही अपॉइंटमेंट देते हैं, हमारे पेशेंट तो खा के ही आते हैं, but still make sure that you give this advice to your patient. So in patient with pump and CGM, be very cautious. Pumps and CGM must be removed from MRI and are relatively contraindicated with ionizing radiation, and plan imaging accordingly. So peri-procedural insulin and medication management, where routine short visit where patient is eating, so no change need there. Basal insulin, continue or reduce the dose by 20% if fasting blood glucose is continuously low for last few days. Try to avoid we need to avoid hypoglycemia. Prandial insulin, we definitely skip the dose if meal is not taken, and dose to correction only, and if eaten, then give the correction dose. Insulin pump, usually continue basal insulin. Use a temporary reduced basal rate if so, same as basal insulin. Longer or sedation case, then coordinate physician-led plan and consider variable rate IV insulin. Post-op reduce oral intake and pain, then applies a sick day rule and keep basal insulin low. Monitor, correct, and ketone check is also required. Analgesia note, where prefer paracetamol. Do not give NSAIDs. Try to avoid it cautiously in most of the patients, especially in nephropathy patients. CGM and diabetes technology, definitely CGM can be used, and this could be really helpful in your procedure, especially type 1 patients. Try to achieve 70 to 180 of glycemic control. Real-time glucose value plus trend arrow before you start. Early low alerts and catch hypoglycemia before symptoms. Reduce need for repeated finger stick interruption. We understand why we use CGM. Caution and limitations. The limitation of CGM, because it has 5 to 10 minutes of lag. Pumps and CGM must be fully removed in MRI. Relative caution with ionizing radiation, CT, and cath lab. Sensor accuracy under anesthesia still being validated, and do not withhold treatment of symptomatic low awaiting sensors. Local anesthesia and vasoconstriction consideration, where epinephrine is definitely acceptable, safe in well-controlled type 1. Low doses of negligible glycemic effect and give profound prolonged anesthesia. So limit dose in cardiac and uncontrolled disease. Epinephrine should be given in limited dose. Adequate anesthesia is equal to lower glucose. So proper anesthesia is given, then glucose is controlled, and it may go low further. Watch for masked hypoglycemia. Sometimes masked hypoglycemia, like perioral numbness, paresthesia that I was talking about, it is common in hypoglycemia as well as local anesthesia. This is why we need to be aware, and CGM can be really helpful in such cases. Antibiotics, infections, and wound healing, where prophylaxis is not routine. Diabetes alone does not warrant antibiotics. So we do not need to give antibiotic to all type 1 patients. When infection is present, then active odontogenic infection like treat therapeutically. Poor control, lower threshold for therapeutic antibiotics, higher risk and severity of infection in uncontrolled diabetes, then drain and debride source and culture if not resolving. And optimize healing. Better A1C control improves the better wound healing and bone healing. A traumatic technique where primary closure where possible, chlorhexidine and rigorous post-op hygiene is required, and review for candidiasis infection with antibiotic course. Periodontal therapy as a glycemic control. You can see here, just by periodontal therapy or the management of periodontal disease can reduce HbA1c even by 0.6%. That was recent in 2025 Umezaki data has shown. So from 0.4 to 0.6% of HbA1c reduction just by managing periodontal disease. Non-surgical periodontal therapy is safe and effective in diabetes. And this Cochrane of 2022, it has shown moderate certainty benefits sustained up to 12 months, and also lower CRP. So infection and inflammation also reduces. Refer for periodontal assessment as a part of diabetes optimization. I will not go into elective surgeries as I already explained, but when it is urgency, what you need to do when pain is there, sepsis is there, trauma is there, do not delay, treat the source, check blood glucose regularly, ask your diabetologist, endocrinologist help, correct acute crisis. Conservative, least invasive options should be chosen. Therapeutic antibiotics if infection is there, physician co-management if required, then refer if it is unstable. In children and adolescents with type 1 diabetes, behavioral gap is there. Many of them just brush for one time. 42% do not floss. So awareness is lowest in age between 13 to 18. Higher caries and gingival risk is, and it is poor hygiene and glycemic variability is high in those age group. Engage that giver in such cases. Short reassurance visit are important. Diet and hidden sugars, where counsel or cariogenic snacks should be avoided, and treat lows. Pair with hygiene advice. So integrate the dental check. Fold the annual dental exam into routine pediatric diabetes review. This is very important. All clinics should have dental checkups, regular annual dental checkup, and especially hypoglycemia is the bigger cause of this dental caries because they eat sugar a lot and they find the way to eat the sugar. So the dental office as a screening frontier in all such cases, where oral red flags are rapid perio breakdown, abscess, or candidiasis, which has chair-side A1C and glucose problem and abnormal results, then refer to physician, diagnosis early, and intervene it early. So why the diabetologist should be a companion? Because diabetes frequently sees patients who skip primary care and a genuine case finding channel. Point of care A1C is there, in the dental chair can flag undiagnosed diabetes and pre-diabetes as well. So this is not for type 1 diabetes. This is for routine patients. Build a two-way referral compact. So ideally, we should have one dental friend nearby whom we regularly can refer the patients. Position the mouth and early warning organ with the diabetes care pathway. So the co-management model of referral and communication is very important for diabetologist, endocrinologist friend, along with dental surgeon and periodontist. So this is a shared responsibility. I'm not going too much into detail as time is pressing. So key takeaways, clinical pearls are that it is bidirectional problem and manage the mouth to help control blood sugar, stratify by HbA1c less than 7%, then proceed freely, 7 to 8% caution, and 8 to 9, then defer elective. Periotherapy pays back, it reduces HbA1c by 0.5%. Hypoglycemia should be managed first. Own the insulin plan and co-manage formally. So with this, I'll conclude my talk with one quote by Dr. Sam G.P. Moses. Diabetes is good disease with bad companies. Keep the mouth healthy and you disarm one of worst of them. With this, I'll conclude. Thank you very much for patient listening.
Congratulations, Dr. Rutul, for bringing that challenges and core strategies in management and the importance of joining hands with the dentist and the clinician diabetologist so that we can offer better for our patient. And this is a very nicely done presentation. Thank you. And keep the questions for the end of the session, please. Okay.
Thank you.
Thank you, Dr. Rutul. Fabulous presentation, I must say. And I would certainly borrow that last thank you slide with the quote from you. That was something which could not read profoundly. So thank you, sir, for the time and your presentation. We move on to the next session now. And I take this opportunity to introduce Dr. Abhishek Raha, who is the next chairperson. Jignesh, slide, please. The next chairperson for the lecture is Dr. Abhishek Raha. He is a Divisional Medical Officer, Indian Railways Health Services. He's located in Assam. He's a life member of RSSDI, IMA, IMA-CGP, IMA AMS, DGNS, Hora Diabetes Society, Northeast Diabetes Society. He's a recipient of Fellowship of Diabetes India. He's a faculty speaker at several national and international congresses and meetings. He has been awarded the best presentation at RSSDI Conference 2022. He's the awardee third prize for quiz competition at Ahuja Bajaj Symposium 2023, winner of the third prize for oral and poster presentation at DTechCon 2024, winner of Fitterfly quiz at DTechCon 2023. He has got several publications in arid journals. Over to Dr. Abhishek Shara for the next deliberation, please.
Thank you, ma'am. Thank you for the kind introduction. So it's an honor to be part of this Diabetes India Oral Health Group, and it's a privilege to be a part of this great webinar after a splendid talk by Rutul sir. Now, I would like to call upon the next speaker, Dr. Jaideep Mahendra. She will be delivering a talk on the periodontal treatment in type 1D management, the role of integrated care. She's the first Indian woman dentist to achieve the PhD in dentistry, first Indian woman dentist to receive the Doctorate of Science in Dentistry. And she has been honored with the Award of Excellence at the International Conference on One Health Frontier. She has more than 300 publications and more than 50 patents on periosystemic health. So I would like to call upon ma'am, Dr. Jaideep Mahendra. She is also the Director of Postgraduate Studies, Professor and Head of Department of Periodontology in Meenakshi Ammal Dental College, Chennai. So ma'am, the stage is all yours. So we'd love to hear about it.
Thank you very much, Dr. Abhishek. Can I share my slides?
Yeah, ma'am, please.
Dr. Jaydeep,
Good
please.
evening, everyone.
Yeah, please make it full screen. Please make it full screen.
Yeah, it is full screen. Is it audible? It is seen?
Yeah, please carry on.
Okay. Yeah, a very good evening to one and all. First of all, it's a great pleasure to be here and to share a platform on this Diabetes India Oral Health Group. And I personally thank Dr. Sangeeta Dheer and her entire team for inviting me for this prestigious talk. And we all know that type 1 diabetes is a serious problem in our country. And I'm just going to talk about the periodontal treatment in type 1 diabetes mellitus patient, the role of integrated care. We all know that type 1 diabetes is basically characterized by autoimmune destruction of pancreatic beta cells leading to insulin deficiency. And we know that the type 1 diabetes mellitus is also known as insulin-dependent diabetes mellitus or juvenile because it's seen to be occurring in childhood and early adulthood, basically below 30 years of age. And this type 1 diabetes can be classified into type 1A, which is autoimmune mediated, and type 1B, which can be idiopathic in nature. So when we talk about type 1 diabetes mellitus as a dentist or as a periodontist, what basically we have learned from our books and our previous articles and so that basically it could be any causes. It can be either genetic predisposition, it can be environmental factors such as viruses or toxins, or might be the diet which can trigger basically the antigen presenting cells, so leading to basically its autoimmune attack. So they basically start attacking the pancreatic beta cells, and therefore these pancreatic beta cells stop producing the insulin. And once the insulin is not produced, the gateway for the glucose is not open for these cells to get metabolized, and that's how the glucose remains within the blood vessels, leads to the type 1 diabetes. So when we look into the epidemiology, we find that, about 9.5 million people still are living with type 1 diabetes worldwide. And if we look into the global incidence in 2025, we find that about 1,64,000 cases occurs in children who are aged below 15 years. Also, global mortality in 2025 has been noted, like approximately 27.3% of the deaths have related, to type 1 diabetes, which has been missed diagnosis or might be, which has come up to be a delayed diagnosis because patients are unaware about, diabetes at such an early age. And as a dentist or as a periodontist, we do find some of the oral manifestations over here in type 1 diabetes. As we have these patients who are very much young patients. They come with a diminished salivary flow, leading to xerostomia in the mouth. They have ulcers in the mouth, and they have a lot of enlargement, gingival enlargement is seen. They have cheilosis, and definitely increased rate of dental caries. Also, they might have, severe periodontitis in case the glycemic status is quite high, and they usually come with the abscess formation. So these are few pictures of the patients within our department, in which, these patients are basically suffering from type 1 diabetes, and they came with a multiple abscess and the gingival polyps. Now, how do we manage such cases? Because these are basically young adults, so they basically go in for the processed food, and it's very difficult to control them. So either they are children, or they are in college, or they are in early, adulthood. And moreover, these young adults, they are always working. They always have some or the other work. So basically, taking care of their health and their diet at this point of time is very, very important. So we have to make sure that we maintain the balanced carbohydrate intake with proper insulin timing. That is very important. Also, we have to prefer the low glycemic index foods to avoid the sudden glucose spikes, because sometimes it might happen. And these kids and these younger adults are very fond of fast food. So we have to make sure that we have to limit all the refined sugars. We have to limit the processed food, avoid skipping meals to, prevent the hypoglycemia, and at the same time to increase the intake of the fiber-rich foods, whether it is fruits or vegetables or whole grain. So we have to make sure that these kids are basically taught together, and we have to counsel them. Also, the nutritional counseling, it is very important because apart from the diet, this nutritional counseling becomes an important part of these patients. These patients, since they are always at work, whether they are in college or school, as I told you, because so most common problem is dehydration. They always remain dehydrated. So adequate hydration is very important to reduce the xerostomia or loss of salivation. Also, diet counseling should be individualized according to the diabetic status of the individual. That is very important. And we need to educate these patients that these patients should know that, oral disease definitely has a connection with the type 1 diabetes. So taking care of their oral hygiene becomes of prime importance. The next comes the exercise. Exercise is very important because we, as a middle age or might be in the older age, all the individuals, they basically they are more experienced about their lifetime and they definitely do exercise. But the younger adults and these adolescents, they are basically unaware of more exercises except very few. So I think at this point of time, at this time period of their life, we basically have to motivate them to basically undergo a good exercise regime, because this will definitely improve the insulin sensitivity. It will also maintain the stable blood glucose levels. At the same time, it will reduce the risk of the long-term complication. That is very important. So I would suggest that every individual, whether he is a very adolescent, definitely about 1.5 hours to 1 hour or minimum half an hour exercise is very, very important in these individuals, that is type 1 diabetes younger adults. These exercise can be either walking or cycling or swimming or little cardio. But I think this exercise is must. That is must, and it should be disciplined. And a few important precautions should be taken in these patients, that we need to monitor the blood glucose before and after exercise, because this is a case because these patients should not go into hyperglycemia, and they need to carry a quick sugar source with them in case anything happens at the time of exercise. A moderate exercise is enough, and avoid strenuous exercise in these individuals during uncontrolled hyperglycemia or basically ketosis. Now, when we talk about dental therapy, I think when these patients who are suffering from type 1 diabetes mellitus, and if in case they are controlled, then I think that the treatment protocol is exactly same as that of non-diabetic patient. They can be treated. And but we have to make sure that we have to keep the appointments very short. Appointments should be atraumatic and stress-free. And usually morning appointments should be preferred in these patients. And we have to make sure that they have taken proper meal and insulin administration before the treatment. And after the treatment, again, the glycemic level should be checked in these patients. And as a dentist, I would say that we have to be very much prepared if in case there is any medical emergency which comes up in the clinic. Now, when it comes to non-surgical therapy is nothing but it is a very primitive procedure, or we can say that it is a basic procedure of doing any kind of dental treatment or periodontal treatment. So whenever a patient comes to any dental clinic, the first treatment what he undergoes is scaling and root planing. That is basically cleaning of your mouth. Then only he goes ahead with the other kind of treatment except any emergency treatment. So it is very important. All these for type 1 diabetes mellitus patients should definitely undergo the non-surgical periodontal therapy. And once the therapy is done, I would say that the re-evaluation is very, very important. We need to check the periodontal status on these patients from time to time. In case these patients are coming with the acute infection, then definitely it should be dealt very promptly, because these poorly controlled diabetic patients may have delayed healing or increased susceptibility to infection. So we have to make sure that we have to take undue precaution for these patients, that they have to treat properly. Now, when these patients have to undergo surgical periodontal therapy. Now, surgical periodontal therapy is one such what we do as flap surgery or any kind of local flap or any perioplastic surgical procedure. Again, this can be done provided that diabetes is well controlled and HbA1c is within the acceptable limit, and we need to monitor healing very carefully. Apart from that, once the surgical periodontal treatment is done, therapy is done, then patient has to go ahead for the maintenance therapy. So this is a very crucial and important phase of the patient, that we need to keep on monitoring the plaque control, whether in case there is any, again, gingival bleeding is there or not. We need to make sure that everything is fine, and we need to check the pocket depth time by time. Apart from that, we also need to check the glycemic status. So this is very important while undergoing any kind of surgical periodontal therapy. Now, why it is very much necessary to undergo oral screening in type 1 diabetes mellitus? As we all know, and the previous speakers have also told that, type 1 diabetes and periodontitis, they share a bidirectional relationship. Why? Because it may happen that poor glycemic control, it increases the periodontal inflammation because of the high blood sugar level in the blood vessels. And on the other hand, the periodontitis, since it is an inflammatory disease, so this may further worsen the negative influence of the metabolic control. So it may worsen the diabetic status. So based on that, I would say that early diagnosis or early identification of the periodontal diseases in these patients is very, very necessary in order to reduce the complication and improve the quality of life. So this becomes important because as a dentist, I've seen that sometimes the patient is unaware about their diabetic status and they come to the department and they basically come to the clinic and with a lot of multiple abscesses and ulcers and bleeding gums. And then we have a doubt, then we basically send these patients for the medical checkup, and that's how we come to know that the blood sugar level is really high. So I think we, as a dentist, are the first people to find or to detect the uncontrolled diabetes in these patients, whether it is a type 1 diabetes or it is type 2 diabetes. So I would say that the risk assessment and screening tools play a very important role here in this scenario. So a lot of questionnaires can be asked from these patients and a lot of questionnaires can be obtained from them. I would say at this point of time, we can join hands with the diabetologist or endocrinologist to make such questionnaires. And we do have oral health assessment tool. We have basic periodontal screening questions with us. And we can also take a visual oral examination when the patient first visits us in the dental clinic. And then with the help of community periodontal index, with the help of diabetes related periodontal risk assessment models, so we can basically sensitize these indices, these tools, even to the diabetologist and to the endocrinologist to make them aware about these models, what we are basically using in our clinic, so that we can join hands with both the fraternity to make sure that we can record the statement and the problems of these patients efficiently. So this is definitely going to facilitate the early diagnosis. This is going to reduce the disease progression, and definitely it is going to promote the interdisciplinary care. Now, there are certain, trigger points of the cross-referral from the medical to the dental fraternity. So there are certain areas where I would say that the diabetic patient should be referred to a dentist. It is when the patient is basically approaching the diabetologist and while asking few questions, he says that, whenever I eat a lot of blood, it comes out while in the food, when I chew or when I brush the teeth. Or sometimes what happens that I have got like painful gums, I'm not able to chew, and I've got very bad breath. People basically tells me that I don't smell okay. So all these are few things which should be taken into consideration. And definitely at this point of time, or at this juncture, I think the diabetologist should think basically for sending or by referring the patient to the dentist. We have basically a consensus report jointly by European Federation of Periodontology and American Academy of Periodontology workshop on periodontitis and systemic diseases. So they have, this happened in 2017. So they have proposed certain guidelines for the physician, guidelines for the dentist, and also guidelines for the patients. So based on this, they have mentioned that the patients with diabetes should be told that the gum disease risk is increased by the diabetes. And if they suffer from gum disease, that is periodontal disease, then their glycemic status may worsen and they are at a higher risk for diabetic complication such as cardiovascular or kidney diseases. And for the children specifically, I would say adolescent who are diagnosed with type 1 diabetes mellitus, their annual screening should be recommended from the age 6 to 7 years, and they should definitely be referred to the dentist. On the other hand, there are certain, factors which says that the patient should be referred from dentist to the diabetologist in case they come to us with severe periodontitis at such a young age. At the same time, they have got a severe gum abscesses. We call them as periodontal abscesses. They have got poor wound healing within the oral cavity. They have got xerostomia and they're not able to chew properly. And apart from that, they're also suffering from polyuria, polydipsia, weight loss. Sometimes they're very fatigued and random blood glucose level is fluctuating. So at this point of time, we should be cautious and we should immediately refer the patient to the physician, diabetologist or endocrinologist. There are certain guidelines which has been mentioned for the dentist as well. They say that the patients should be given preventive care regime and should be monitored regularly. And these patients with type 1 diabetes presenting with any acute or oral, or might be, we could say that periodontal infection require a prompt oral and periodontal care and also the diabetic care. Now, what is the importance of these cross-reference from endocrinologist to the periodontist and then from the periodontist to the endocrinologist? It's going to encourage the integrated healthcare. Definitely it does. It also helps in early diagnosis of the undetected diabetes, which usually the dentists pinpoint out, and it also improves the periodontal and glycemic outcomes. So this is very important. And then there are certain oral self-care measures which the patient should also think about. So I think it's important at this juncture. I think it's basically duty of a dentist to educate the patient, specifically type 1 diabetic patient, to work on these factors. First is that he has to brush twice daily using a fluoridated toothpaste. He has to use soft and medium bristle toothbrush because his gingiva would be very febrile and soft at this point of time. At the same time, he has to undergo interdental cleaning, whether with the help of dental floss or interdental brushes, or he can use some antimicrobial mouth rinse. Also, a regular professional, or I would say that a regular dental maintenance checkup should be there every 3 to 6 months to maintain the optimal glycemic control. Also, there are certain guidelines recommended by the workshop which happened in 2017, and they say that if your physician has told you that you have diabetes, you should make an appointment to the dentist to have your mouth and gums checked. Number second, it is because the people with diabetes have a higher chance of getting gum disease. So gum disease can lead to tooth loss and may make your diabetes much worsen. So I think if these slogans and these pamphlets can be stuck up to the any diabetic center, so the patients who are coming to who are coming for the diabetic treatment, definitely they would read this and the awareness would be spread so that they can have a checkup with the dentist as well. So there are certain recommended schemes which I would suggest and policy making for type 1 diabetes. We can say that these patients can definitely we can enter their patients' data into a digital system, which can further get uploaded into the type 1 registry, which we can say that it is a national type 1 registry platform, so that once it is registered, we are able to know the prevalence and the incidence of these diabetes nationwide. So once it is done, and once the electronic health records are maintained, once the national immunization registry is also done, then we can go ahead with a proper protocol, treatment protocol and preventive protocol to address this problem. Also, the affordable or free insulin should be available to all the hospitals and centers, specifically for the poor population, for the rural population where the parents are illiterate and where the children are also not aware of their problem. And also, I would say that few monitoring, diabetes monitoring technologies such as glucometers and insulin pumps and CGS system should be available at a very subsidized rate to these individuals in all the clinics. And I would say that the proper screening camps and with the good community outreach program, we can definitely make aware about this type 1 diabetes problem to the public at large, so that the early detection can be done, timely diagnosis can be made, and then an early treatment and better outcomes can be obtained. Apart from this, I would say that, some sensitization can be, and some training program can be provided to all the healthcare professionals, such as physicians, nurses, dietitians, dentists, dental hygienists, community health workers as well, to know the serious problem about the type 1 diabetes and the connection with the oral diseases. Because mostly we all are aware about the various manifestations of the type 1, but a very limited people would be there who would be knowing about the oral inflammation and their connection with the type 1. So it's a time when we need to sensitize them and we need to train our healthcare professionals. And at the same time, we have to make sure that the public would be aware of this type 1 diabetic problem, that it can worsen if in case you do not maintain your good oral hygiene. And at the same time, I would also recommend that some money and some funds can also be allocated for research and innovation in this scenario to make a better future for people with type 1 diabetes. Also, the public-private partnership is very important. I would say that with the help of academic institutions, government, industries, NGOs, various NGOs, and with the help of patient advocacy groups, we can basically collaborate, and so that we can spread awareness about the dental inflammation, about the oral inflammation and type 1 diabetes mellitus to the mass, to the public, to make them aware about the serious problem and how to prevent. So there are certain central governmental schemes also which has been there for a longer time, but however, none of the scheme was made specifically for type 1. But most of the schemes, they cover non-communicable disease. We have National Program for Prevention and Control of Non-Communicable Disease, in which we have diabetes. So children with type 1 diabetes can also be covered. Then we have National Health Mission, that is Free Drug Service Initiative, which provides financial assistance for supplying the essential medicines, including insulin. Also, the other governmental schemes such as Ayushman Bharat Pradhan Mantri Jan Arogya Yojana is there, which basically covers the eligible families for hospitalization expenses related to diabetes complication. We have Ayushman Arogya Mandir, that is Health and Wellness Centers, which provides follow-up, counseling, referral services, and continuity in care of the diabetes. Here again, type 1 diabetes mellitus is also covered. We have Pradhan Mantri Bharatiya Jan Aushadhi Prayojana, so which makes a quality generic insulin and other diabetic medicines available at a very subsidized cost. Last but not the least, I would say that very lately in 2026, some guidance document has come up only for type 1 diabetes, that is in children. It introduces India's first national framework specifically for childhood diabetes, and it recommends that standardized diagnosis, lifelong insulin therapy, caregiver education, free essential diabetes care at public facilities, and integrated referral pathways can be provided to the young adults who are having type 1 diabetes, and definitely we can further make sure that the complications can be prevented. So to conclude, I would say that type 1 definitely it has the bidirectional relationship with periodontitis, with the gum infections, which is mediated by chronic inflammation and immune dysregulation. And hence the multidisciplinary approach involving physicians, dentists, and periodontists becomes utmost important, very important, to improve the diabetic and the periodontal outcome. So I think together we can join hands to make our diabetes and the oral inflammation gets prevented in near future to make our Bharat a healthy Bharat. Thank you very much. So I would like to thank the organizing committee, especially Dr. Sangeeta Di, Dr. Anurag, Dr. Gunjan, and Dr. Sumita for organizing such a wonderful platform, for giving an opportunity to both diabetologists, endocrinologists, and to the periodontists to share their views and expertise in this common platform. Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you so much for a wonderful presentation. I think it is very well organized and very well deliberated. So thank you, ma'am. We're privileged to have you on board today.
Thank you so much.
Thank you, Dr. Abhishek. Thank you, Dr. Jaydeep. Insightful lecture. And it was interesting to hear the in-depth coverage that you have given. Thank you so much. We now move on to the last lecture of this session. May I ask Dr. Gunjan to kindly introduce the chairperson for the next lecture? Dr. Gunjan? Dr. Gunjan?
Yes, ma'am. Am I audible?
Yeah.
Am I? Yeah. A very good evening to one and all.
Jignesh, Dr. Priya Yadav का slide दे दें.
So it's my privilege to introduce the next chairperson of the session, Dr. Priya Yadav. She completed her graduation in the year 1999 and post-graduation in the year 2001 from MCODS Mangalore. Currently, she is working as Director, Professor and Head, Department of Periodontics, ESI Dental College and Hospital, New Delhi. She has a vast teaching experience of more than 24 years and have various publications in national and international journals. She has been a postgraduate guide and an external evaluator for PhD research work. Academic interest lies in the field of periodontal medicine, management of endoperial lesions, and regenerative periodontal surgery. She has been appointed as a member of Interview Board Standing Selection Committee of reputed government institutes in 2019, 2023, and 24. She has been an active member of ISP and DIOH, appointed as reviewer for NEET exam at National Board Examination of Medical Sciences, Delhi. I welcome Dr. Priya Yadav. Over to you, ma'am.
Thank you, Dr. Gunjan, for the kind introduction. And since we are at the last leg of this webinar series, a very good evening to one and all. And there couldn't have been a better culmination of webinar series than to hear Dr. Dominica, who has experienced type 1 diabetes mellitus herself. I have heard about her experiences before, and she shares them very extensively. Being a dentist herself, she'll be able to give us a greater insight about how to tackle the condition more effectively and what should we be primarily focusing on. So welcome, Dr. Dominica, waiting for you and waiting, to hear again from you. So she's a dentist with a specialist interest in periodontology, advocate for the connection between oral health and diabetes using AID-DI system, living with type 1 diabetes since 2018, combines clinical expertise with lived experiences to deliver empathetic and informed patient care, did her dentistry in 2018 from Medical University of Warsaw, 2019 postgraduate diploma from King's College London, and finished with her MSc Diabetes Practice from Swenia University in 2021. You are most welcome, Dr. Dominica. Waiting to hear from you.
Good evening, everyone. Thank you, Dr. Sanjita, Dr. Anurag, and the IOH group for the invitation. It's a pleasure to be there. I don't have my slides because I believe that lived experience doesn't require slides. I was diagnosed with type 1 diabetes only 2 weeks after I finished dental school back in 2018. And I had a privilege to obtain access to technology very early on, as I was using CGM only 2 weeks after my diagnosis. And I think one of the main points I would like to give during today's evening is to emphasize how important it is for every person living with diabetes to have access to these devices, especially continuous glucose monitors, which allows us to learn about our blood sugar, how we respond to food, how we respond to insulin, and they sort of are GPS for us, and it's very important to have access to them as early as possible, because then we are able to avoid a lot of unnecessary mistakes. And unfortunately, I'm aware that the situation looks very different in different part of the world. But I believe that as dental and medical professionals, we can be advocate for a better access to this technology. I was using multiple daily injections for the period of 4 years after my diagnosis, and sometimes it has been very challenging, as it's not so easy to give yourself such a precise doses to cover specific foods, especially Indian food. and it caused me different problems for my journey with diabetes. And I was afraid to eat pizza for the period of 4 years, and I also a big fan of sports, so it was quite challenging to adjust the timing of insulin before and after my activities. So I was very grateful when I was introduced to insulin pump for 4 years after my diagnosis, and was able to use since then automatic insulin delivery system. And currently I'm using the pump, which is Omnipod Dash, with the CGM Dexcom G7, and the artificial pancreas system called Trio, which allow these two devices to communicate with each other. And I cannot tell you how badly and how good this has improved my life. And I was diagnosed with diabetes very late in my life. I was 25 years old, and I really remember my life before having to deal with diabetes, when I didn't have to count carbs or think about insulin, or just didn't have to do additional 180 decisions per day related to my diabetes treatment. And yeah, these devices are making a huge difference in daily life of every person living with diabetes. So if you ever have a chance to advocate for people living with diabetes to have more access to these devices, please don't hesitate to do that, as they are really life-changing. And I think that's my first point. And the second point, from the perspective of a person living with diabetes and a dentist, I think it's very important to pay attention to those patients who have diabetes and who are coming to your office and they don't have awareness of hypoglycemia. So it's very crucial to be prepared for such events, and always to have sugar, glucose in your office. I have it in mind all the time. Be able to recognize the symptoms and give support to the person living with diabetes as early as possible to resolve this kind of situation. And I think thirdly, for us dentists, it's very important to use the time of our dental appointments to also educate our patients who are living with diabetes about this bidirectional link between diabetes and periodontal health. Very often, these people, they have so many consultations among so many different specialties that dental health is not underscored there. So I believe it's very essential for us dentists to use our role and to educate them throughout these appointments, and especially about the behavior after hypoglycemia. As you know, if you like to treat hypoglycemia, you need to consume sugars, and very often hypoglycemia happens at night as well. So it's important to let your patients know that it might be helpful for them to rinse their mouth with water after such an incident during the night, and don't brush their teeth immediately, so they could avoid the erosion of their enamel. And yeah, I think these are the 3 main points I would like to present tonight. And if you have any questions, I'm happy to take them.
Thank you, Dr. Dominica, for sharing your experiences. You said you were diagnosed late at the age of 25.
Correct.
Did you notice any oral changes, in the soft tissue or something like that?
So I think 2 days before my diagnosis, I had little red spots on my palate. And also I've experienced a lot of dry mouth, a lot.
Okay. Okay, thank you so much.
Thank you.
Thank you, Dominica. It's a pleasure to hear you again. And believe me, T1D champion is what the correct terms apply. And thank you for sharing your part of the journey with us. And that will be taking a life lessons from you as well. Thank you so much for being a part of the show. And we now come to the part conclusive end.
Pleasure. Thank you.
To Dr. Anurag for the key messages and summing up.
Thank you, ma'am. It has been a wonderful evening and an excellent session with the luminaries who have shared. Now we started with Dr. Sujay Ghosh, who spoke in detail about the diagnosis, the clinical features, and he emphasized that TKA should be kept in mind, the various kinds of insulins which needs to be known, and how it is difficult for the patient as well as the clinician to know about the food and the glycemic index. Thanks to Dr. Neeraj Goglani, who emphasized how it is important that the T1D children needs to be taken care of, what we need to be aware of, the gingivitis, the xerostomia, and the chorionic biofilm shift which happens in the children, and the candidiasis, which is a common occurrence. And a lot of, because of the shortage of time, we will not be able to go into the details of the rules and regulations. But in short, how Dr. Ritul Goklani, in his wonderful presentation on Sugar Smile Axis, covered the 6 complications of diabetes mellitus, and that the oral health is a modifiable risk of diabetes mellitus. The shared responsibilities of both the dentist as well as the clinician in managing the T1D patients, both in the dental clinics as well as in the diabetic clinics, is important. Then Dr. Jaideep Mahindra, who spoke about how the periodontal management of the T1D patients is important, the scheduling of the appointments, and the care of the patients with asepsis and keeping a track of the delayed wound healing. And finally, our friend and guide, Dr. Dominica, who has always been with us to share her experiences, and we learn from her and shall keep on learning with her. So with this, we wrap up with these key messages, and I hope that these messages, as they reach to the wider audiences, are more and more discussed, and they are helpful for the general masses. Thank you again, ma'am. Thank you.
Thank you, Dr. Anurag, for wonderfully covering the whole show and summing it up in few words. That's a gist that we take away home. Type 1 DM is a challenge, and the more we learn, the more we share, and the more we educate ourselves. With this, we come to the final leg and conclusion of the webinar. I thank all the delegates, all the faculty to be a part of the show. And just for information, delegates, you can download your participation certificates after the webinar, and their faculty appreciation certificates will be emailed to you shortly. And last but not the least, we all should raise an applause to the backup team of the Event Management of Diabetes India. RS events, without these guys, I think we cannot have a seamless conduction of the online and offline events. Thank you, Jignesh, for the show. And with this, we wrap up, and till we meet again, it's bye for now. If all are available, we can just quickly see ourselves if all are available. Otherwise, bye for now from us. Okay,
and ma'am, one more thing. I would also like to thank the backbone of our DIOH, Dr. Sangeeta Dhi, for orchestrating the entire webinar so well. Thank you so much, ma'am.
Not at all. It's a team effort. All of us keep on patting each other, and that is how we keep
Thank you, ma'am.
Thank you, Sangeeta.
Thank you, ma'am. Thank you for having us. Thank you for having us as a part of the team.
Thank you. Thank you. Thank you. Thank you. Bye-bye.
Bye-bye. Thank you.
Bye.